Good evening, everyone. It gives me immense pleasure to welcome all of you to yet another series of the Foxy Presidential Initiative of podcast. And today we are doing the 22nd episode, which is a program that has happened every day, 8 p.m. onwards, since the 29th of January. First of all, we have with us today Dr. Sunita Tandulwadkar ma'am and Dr. Palaniappan sir, who are Dr. Palaniappan sir is the guest speaker today, and Sunita ma'am, of course, the ever inspiring, ever smiling, and always gives us confidence and also gives us a lot of work to do. But with enjoyment, we do the work because she gives us the encouragement for the same as well. So today we are going to discuss anemia in pregnancy. And before we start this program, as always, we are going to have a short but a very sweet message from our respected president, Dr. Sunita Tandulwadkar, ma'am. Ma'am, as we know, she is the president of Foxy currently. She's the president-elect of ISAR. But more importantly, for all of us, youngsters and otherwise, she has been a person who has given us a platform, encouragement to take things forward and to look at things the way we want to look at with her backing being there with us always. So, ma'am, it's always a pleasure to work for you. It's a pleasure to do programs for you because we know that you will be there as a support and you will be there for all that we do with a lot of positive energy. Ma'am, I request you to say a few words on this 22nd episode of the Gyan Pravah podcast series. And today our topic is anemia in pregnancy.
Thank you. Thank you, Priyankur. And it's so wonderful. I have my favorites in the frame. 22nd episode, Priyankur. 1 month and 10 days over. Today is a special day because it's my father's birthday also. He's no more here, but it would have been his 95th birthday. It is a president's initiative, but initiative for my committee chairperson. 30 committee chairpersons, 30 days, amazing energy, amazing podcast. It's fulfilling my year. Everyone says in 1 month we have done amazing work. Out of this, 22 are by my chairperson who have done podcast with academic or non-academic topics, and every podcast was better. And I'm sure today, Anemia, none other than Palani, giving his all important messages, the questions asked by Priyankur, another teacher of teachers, Sablo. It's so beautiful to see you all. I don't want this year to end early. We already did launch of Arogya Yoga Yatra in Tirupati, and today I'm at Rishikesh for a second journey of Arogya Yoga Yatra. We did beautiful launch of Doti Ke Jindagi Ke on 4th February World Cancer Day, and I'm so thankful to 100 societies who did this program to launch this very beautiful initiative of cervical cancer elimination. I'm sure, Priyankur, this academic probably will remain one of the best program on anemia in pregnancy. And I'm sure it's not only the faculty who are listening, the delegates who are listening, the postgraduates who are listening, the teachers who are listening, everyone will learn at least something different. Thank you so much for taking this initiative to this level. And Palani, as our protocol, I'll join from my delegate link and I will enjoy the dialogue between both of you. Thank you. Back to you, Priyankur.
Thank you, Sunita ma'am. Once more, it's a pleasure for me to host this program. And of course, I'm sure Palaniappan sir will join me in wishing, of course, your father. I'm sure he's looking at us and he's looking at us with a lot of pride today. You are in Rishikesh today, ma'am. Thank you so much for joining. In spite of being there, just reaching there 10 minutes back, as you shared with us. Enjoyed the journey last time as well through Rishikesh with you. And today, virtually, I'm enjoying this journey as well. So thank you so much, ma'am, for being here. It's always a pleasure to do everything for you. Thank you so much, ma'am, once again.
Thank you.
So
Can we
today we
introduce
have our
Palani?
guest.
Yeah.
Thank you so much, ma'am. So today we have our guest speaker with us, none other than Dr. Palaniappan sir. He, as we ma'am has said, is a teacher of teachers. We have always learned from him, and more than learning from him about the subject, we have learned always from him how to make PowerPoint slides. It's always, I'm sure people who have seen his slides have always enjoyed it. Lot of music, lot of pictures from Mahabharata, Ramayana, movies, etc. And it's wonderful learning from you always, sir. And I'm sure we're going to learn through this dialogue a lot as well. Sir is currently the professor and head Department of OBGYN at the prestigious Sri Ramachandra Medical College in Chennai. Sir has won the Dr. Kamini Rao Yuva Foxy Orator. He is currently the vice president of Foxy. He has been the president of OGSSI, there's the prestigious society in Chennai, and he has been the chairperson of the Safe Motherhood Committee. I'm sure Sir's students are looking at him with pride, and I am here to learn from him a lot, and that's why I'll not waste more time in introducing him, but we'll straight dive into the topic of anemia in pregnancy.
Thank you. Thank you,
Thank you
Palani.
so much, ma'am.
And Palani, you are my one of the most wonderful vice president. Any responsibility I give you, you do it with so much of a elegance, sincerity, honesty. I know the day when you will take over as a president of Foxy, I'll be enjoying that year too. Thank you.
Thank you, Dr. Sunita. That was wonderful. I am stumped. That's all I should say. I'm stumped by your presence and by Priyanku's words, and I'm sure people are watching. And thank you very much for making this presence from Rishikesh, and of course, the blessings of your father as well on his birthday. Thank you very much, and I'm happy to be associated with you as the most enthusiastic president of Foxy. Thank you very much.
Thank you so much, sir. Thank you so much, ma'am. So we dive into the topic of today, that is anemia in pregnancy. So when we did think of this topic of anemia in pregnancy, the first name that of course came through my mind was of Dr. Palaniappan, sir. We have seen him work through and through with anemia, and this is something that we really wanted his insights regarding various topics. So we will have probably a time for around 10 to 12 questions that we'll take from sir, opinions of sir, to look forward to how to better the health of women in the country, and also to look at how we can go ahead in managing, or rather before managing, preventing anemia, which will be the foremost goal for most of us. So if I come to you with the first question, why do you feel is anemia a significant concern in women's health, especially in the developing countries like us, like in India?
Thank you, Priyanku. That was a very pertinent question to start with. And what we need to understand, why is it important in India, especially in pregnant women, is that we need to understand 40 to 60% of maternal deaths are generally related to anemia, whether as a direct cause of maternal death or as an indirect cause of maternal death. And whatever methods we do and we go ahead and do, India's population is its strength, its weakness as well. Having said that, because of the population, of course, yes, the birth which we all give to women as obstetricians, what we need to understand is anemia affects both the baby and the mother very significantly enough in various streams, whether it be to start with as a girl and then to go on as a mother and then to go on as a grandmother. Anemia can have its own long-term implications. And so we need to be bothered about anemia in pregnancy, especially. So,
Perfect, sir. So
yeah,
I
go
think as sir has very right. Yeah, you want to add on, sir? Please go on,
on, go
sir.
on, go on, go on. Okay, go on.
Yeah, so I was just saying that, sir, I mean, like we all know that South India is probably one of the states that we look forward to. Tamil Nadu, Kerala are the states definitely that we look forward to for various management modalities, for various prevention modalities, etc. And currently, we know that Kerala is the state with the least maternal mortality, of course, very closely followed by Tamil Nadu currently as well. So, in that sort of a scenario, when you look at, I think there could be none other than Sir, that is Dr. Palaniappan sir, who will be briefing us about this various aspects of probably managing cases of anemia. And it's very aptly said that population is our benefit and it's our problem as well. I think most of us, whatever we do in this country, the major bane or boon, whatever you say, is currently the population. I think that is a factor that we need to deal with. There are various government programs that have come in. There are various aspects of various programs to deal with the prevention of anemia, but the problem, again, the population and how much can the government cater to is something that we are probably looking at. So, sir, if a woman, probably some of the women in the rural population do not go to the doctor at the first point of time. So they basically are at home. So what would be your message to tell them when they should be concerned that they could be probably getting anemic, and what should be their threshold when they should come to the hospital to look at or to come and show to someone that probably I think that everything is not all right with me.
Having asked this question, I think if it's going to be related to pregnancy, we probably would think in terms of screening women at the booking visit. So the minute she loses her menstrual cycle and she says that, oh, I'm amenorrheic, am I going to be becoming pregnant now? I don't know. So that point of time will probably the point of contact and the best time to screen for anemia. And I'm sure that most of the hospitals, most of the women do it. But having said that, are we only picking up anemia in pregnancy? The question now is just we've had Dr. Sunita see here, and her vision was absolutely beautiful. She always says that, oh, when we go for a trip to Rishikesh, for example, very simply, oh, don't we look into our passport, tickets, our handbags, our dresses, and whatever, when we go on a for whatever trip. So that is preparedness for pregnancy is what is very important. So over this is what she has thought about a project called as KYN, or Know Your Numbers. So according to the present president's vision, which is fantastic, is that a girl who's a female child of 8, 9, 10, whatever age, maybe when she's going to even attain menarche and maybe after menarche, should probably know her numbers. By virtue of being a lady, a girl, she needs to know her numbers, and we need to be prepared for pregnancy. So once we get prepared for pregnancy and we know that her hemoglobin is only 8, 9, oh, then she's not ready for pregnancy. Then she's probably ready for treatment of anemia first. So we have to pick up there. So we need to always think in terms of the old saying, prevention is better than cure. And in Tamil Nadu, we say, Vandapin parpom illa, varumun kapom. So we always do before what we see is what is important. And so she probably needs to get prepared at that point of time itself. We need to pick up whether she's anemic or not, prepare her for pregnancy, and then she becomes pregnant. For a pregnant woman, probably we will try to screen for anemia at the booking visit, which I think many of the hospitals still do.
Perfect. So I think sir stressed very vividly about the periconceptional care currently. We have a lot of women who come to us today saying, in Siliguri, off late, I am from Siliguri, so in this place, I off late see, sir, a lot of patients who come and tell us, we are planning to get married. Is everything all right? I mean, that is a change that I've seen off late happening, and that I think is a very positive change that is there, because we do look at a lot of HPLCs, we look at thalassemia, whether it's a major for both the partners, etc., which is quite very important and vivid. But as you said, sir, I think periconceptional care or periconceptional, testing is something that is important, because before they get pregnant, if we can catch the anemia, if we can catch the hypothyroidism or hyperthyroidism, I think to a certain extent we could go ahead in preventing, pregnancy losses as well. Sir, how do you think will anemia affect a woman's reproductive health?
Anemia in a women's reproductive health can affect very vividly, as what we started with, whether she's a girl, a pregnant lady, a little later than mom, or a grandmother. I'm sure anemia will affect. So from womb to tomb, anemia can affect a lady. And so we need to understand that for a mother, she will be with profound weakness, lack of energy, poor work performance, whatever work she does, even if she's a household employee, and poor work performance, and of course, increased cardiac stress if she's going to have anemia or even a borderline anemia. And if they're looking in terms of pregnant women, then the fetus will probably have a small for gestational age baby, or maybe a growth restricted baby, or maybe even a preterm labor and things like that. We always say so as a teaching dictum that baby sucks blood from the mother. Yes, it sucks. And so the baby does not get usually affected by anemia because the liver compensates and copes up for the loss, whatever is being done. But it's the mother again who becomes very badly affected. So having said that, the whole nation probably is watching today. We will say that the babies don't become anemic. Let me make that very clear. They don't become anemic because they are a parasite inside the mother. So they suck the blood from the mother and take off the stores of the mother. And they will, on the other hand, have a small for gestational age baby, or an FGA, or a preterm labor and a preterm baby, but they may still not become anemic. Oh, but the mother becomes extremely anemic, cachexic at the end of pregnancy. And so it will become a very severe anemia, very difficult to treat. So
Perfect. I think very important message given by Sir that we have to give time between pregnancies for the lady to cope up with pregnancy, because the parasite in her, the baby, might suck in more blood and she might be in a state which will be not probably reversible at some point of time, leading to cardiac failures, etc. So, Sir, the next thing about prevalence. What do you think are the prevalent risk factors for anemia in women, particularly during pregnancy?
During pregnancy, what we need to understand is, first of all, the diet which she takes. So, as we said, preparedness, she's a lady with low iron stores, obviously, yes. Then, of course, her poverty, ignorance, lower socioeconomic class comes into picture. That's a major risk factor. Then comes into picture, oh, she becomes pregnant. Oh, yes. Then comes the hyperemesis gravidarum in the early first weeks of pregnancy, because physiological hemodilution of pregnancy happens at the 7-8 weeks of pregnancy, and the hemoglobin takes a little bit of time for the RBCs to improve, while there is your plasma volume, which expands very tremendously the minute she becomes pregnant, and she will look absolutely papery pale. So the physiological hemodilution takes into account, and she has hyperemesis at that point of time, and she will not be able to eat even her natural, normal food which she's been taking. And then comes your food faddism. Then comes your pica, which is very, very common in most of the parts of the country, and they eat unwanted and uneven, unheard of things. Then, of course, comes the basal iron, which is very low, which we were talking about. And then comes your habits like alcohol, tobacco chewing, etc., etc., etc. Then we also have something called as defective absorption, which contributes to the risk factor for anemia. Something like a worm infestation, still very prevalent in India. And we need to say that India is still in the tropical country. So we need to say worm infestations, amoebiasis, giardiasis are quite common. Having said that, in India, which we said in the beginning that population is our boon and bane, we need to say that frequent pregnancy. Yes, one. Two, menorrhagia, and of course, melena and features like that, which will contribute to anemia. We also need to understand that pregnancy itself can complicate as a risk factor for anemia, because frequent pregnancies, a twin pregnancy, a triplet pregnancy, etc., and a postpartum hemorrhage following a pregnancy would also contribute to your anemia. Last will be your inhibitors of iron, if you're thinking in terms of only iron deficiency anemia, which is probably the most common form of anemia. Something like a phytates, tannates, calcium given together along, or at least taken together along with iron, tea, coffee, herbal drinks, and in the high elite group, the Chinese teas and the Japanese teas, which are very good in antioxidants, may be very good for you and me, Priyankur, but not for the pregnant women who are iron deficiency, because they inhibit the iron absorption completely. So they need to be advised not to take any of those herbal teas and drinks. Yes,
Perfect,
these
sir.
are the risk
Wonderfully
factors.
answered. I think you have briefed very beautifully the various points, the various risk factors which could be there, sir. Thank you so much for that. Now, of course, the most pertinent question, India being the majority of the people in India being under the below poverty line, socioeconomic status definitely plays a very important factor in our in the women that we treat and we see. So, sir, any opinion of yours that you'd like to put front over here about the socioeconomic status which plays a role in the prevalence of anemia? We definitely know low socioeconomic status is a factor that is there for anemia, but to certain extent we also see that little not so low socioeconomic status also could be little in the bracket of anemia as well. So, sir, could you elaborate, please?
The socioeconomic class makes a lot of difference. So if you say the very poor socioeconomic class, and then probably the little not so and the elite, anemia can become prevalent in any of these population, no doubt, even if she's an elite lady. So in the very poor or the low socioeconomic status, of course, overcrowding and poverty, of course, the food habits, which we did mention, sharing of food, and of course, in India, we need to think in terms of women taking the leftovers of the entire family. So the husband eats first, then the children eat next, and then comes the lady who's pregnant, and she eats the leftovers and not the prime food. So that is something which makes a lot of difference in a lady who's in the lower socioeconomic class. And of course, your habits of the lower socioeconomic class, your worm infestations, sharing of toilets, if not sharing of toilets, the open toilets, and so the worm infestations, which is very, very common, as we did say, the tapeworm, fish tapeworm, whichever tapeworm, and of course the roundworm and the entropius, etc., needs to be taken into consideration. All these will affect the lower socioeconomic class. Coming to the little middle class, Of course, all of them can affect a little bit, and the worm infestations will affect. Coming to the elite, as we said, oh, they go and have a Chinese tea, they have an alcohol, they have smoking, and such habits will obviously affect the anemia in pregnancy. So it can affect any cadre of women, and all socioeconomic classes will be a brunt to anemia in pregnancy, especially though the lower socioeconomic being the highest.
Perfect. I mean, beautifully highlighted and beautifully pointed out, sir. So we need to understand that it's not only the low socioeconomic status that is affected, but every woman can be affected. We need to test, we need to do a universal testing and take it forward from there. Now, the most important question is about signs and symptoms. What is the most worrisome sign and symptom if you look at? So symptoms, yes, you could highlight a few, and then signs are what we need to look at when we need to pick up anemia in this woman.
The signs and symptoms of anemia and pregnancy, we need to understand it will mimic pregnancy itself. Or should we say, pregnancy itself can mask the signs of anemia, because you can have fatigue, lassitude, weakness, tiredness, laziness, etc. All of them are symptoms common to pregnancy and to anemia. But when a lady is excessively tiresome and fatigue, especially when it is noticed by the husband or the mother-in-law or the mother, we need to think in terms of, oh, this girl was not like this a month back when she was not pregnant. She's extremely tired. So that is something which needs to be brought into the point of, to the doctor, and then they need to visit a doctor. This will be the most common symptom. Coming to the little bit of signs of anemia, what they can have is they can have palpitation, a rebound, whatever. So that is what is probably the first sign which they can get into. So this was the very initial status. What happens in our movies is that, oh, they will catch the pulse of the lady and they'll say she's pregnant. Oh, it can never ever happen. Never ever happen. And I always wish that such movies could be sued, because you can never diagnose pregnancy with pulse, right? That's what happened in the Vedas and Mahabharata and Ramayana time. Oh, it can never happen now in the modern world. But what was happening with the pulse was that it's a rebound, absolutely threading, absolutely bounding pulse with a little bit of tachycardia. But please understand that can happen in anemia and can happen in congestive cardiac failure and in thyroid disorders also. So that's not a sign, but that is one of the signs, but not the most important sign. Is a derogatory sign of anemia, but it's a sign of anemia. So the pulse will give us the first indication that, oh, this lady may be anemic. Then the next sign, of course, slowly we'll start checking into the pallor. And I always say that the pallor has to be looked into the soft palate, which does not get stained. Why are we thinking of the soft palate? Oh, the eyes, the conjunctiva can be masked by the mascara and the eyelashes, which the high-end women wear. Priyankur, you asked me that. The tongue can be coated by betel nut, the lower socioeconomic class, put that, and so we will not see. The palms and soles may be with mehendi, and we can, and the nails can be with a nail art, which is beautiful in the higher socioeconomic class. So anemia can be masked there. Whereas the only place which does not get stained is probably the hard soft palate. And so please always look into the soft palate with a good lighting, and you will see anemia. It does not stain at all. So that's the first sign to come in place to see for anemia. Of course, you in a very pronounced and an advanced anemia, you could have angular stomatitis, glossitis. In a B12 deficiency anemia, probably your tongue can be beefy red. In a folic acid deficiency, your tongue could be a lemon yellow tint, whereas in iron deficiency anemia, the tongue will be papery pale white. And of course, in advanced B12 deficiency anemia, you could have paresthesia, numbness, and tingling sensation and peripheral neuropathy. And in a folic acid deficiency anemia, you may not have that. Coming to seeing the patient up down, you may have a raised JVP if it's an advanced stage and just going near failure. Of course, you could have that. And you'll have other features of failure of the heart failure, which is extremely dangerous and rare. So these are the signs and symptoms which we need to be very cautious about in a pregnant woman.
Perfect, sir. Very beautifully highlighted. So what we need to understand is see it where it needs to be seen, and we should not see where it is probably will not give us a picture, is what sir highlighted very beautifully. So you need to look at it, and of course the famous saying goes, only your eyes will see when the mind knows it. So you need to know where to see, so then only you will see in those places. Beautifully highlighted, sir. Thank you so much. Now, of course, we all say that diet and nutrition is quite important in preventing and managing anemia. So, sir, we would like to ask you, what preventive measures would you tell in a woman to reduce the risk of developing anemia, and also highlight a little bit towards the diet and nutrition of this woman as well?
I think we were just about to talk to Dr. Sunita about this and the Sampurna project, which was launched by her very recently in the Fogsi initiative, and how we would be prepared for pregnancy, and the know your numbers and Sampurna being absolutely related is that we would make preconceptional absolute pack up and say, oh, what are all the things a preconceptional women needs to understand and know, keeping the KYN and number. And of course, when she becomes pregnant, her diet and what is important was very well illustrated. Most of the programs, it may look very simple, but that's what is the state of the art today for the Indian population. And so what we need to understand is the women needs to eat a lot of protein diet, a little bit of carbohydrate. So we always say that there is a plate, and we divide that into three columns and say what is more important in an anemic patient. It is the protein and not the carbohydrate, which we are all very fond of. And so it's not just the rice or the chapati which makes the lady fulfill. It will fulfill, but it will not fulfill anemia, whereas it's only the dal and the sabji and the vegetables which makes. So she needs to probably take a lot of green leafy vegetables. And if she is going to be a vegetarian, then some form of protein like paneer and egg. And of course, if it's a lady with a low socioeconomic class, she can take the drumstick leaves from whichever garden she's on the road, and she can make the drumstick leaf. Jaggery is a very rich source of iron. And of course, if she's able to afford to your higher socioeconomic class of what we said, of course, dates are something which she can always take, but it's expensive. We need to understand Arabian dates, very nice, but then expensive though. So we can cater the food according to the population. And groundnuts are a very good source of iron, low cost source of iron. And of course, it caters to the population. We also need to understand somebody in Gujarat who will take a goat's milk, and we need to understand goat's milk is devoid of folic acid. And so folic acid anemia can be prevalent in those areas where they drink goat's milk. And folic acid is destroyed by cooking. So folic acid is not available in cooked food. So cooked food, folic acid gets deficient. And so we need to understand that that lady needs to, if she's diagnosed with folic acid deficiency, she needs to take a lot of raw green leafy vegetables. And of course, in vegans, and I wouldn't say vegetarians, B12 deficiency is more common because of the heme, non-heme blood components. And so we need to keep in mind whether she's a vegetarian, a vegan, and put into consideration, or maybe she's B12 deficiency anemia. So we need to screen them also for B12.
Perfect. So I think anemia only always doesn't mean iron deficiency, as sir highlighted. It could be B12 deficiency as well, which we need to look into. So we have looked at how to diagnose. We have looked at the prevention strategies. We have looked at how important it is to look at the risk factors, signs and symptoms. And now comes the most important part. How do we manage, or how do we treat? So sir, can you highlight on the basic or the current treatment options that are available for managing anemia?
I thought we also need to say before we manage, we need to know the type of anemia, what we're going to do. So there are a few population who will have to see that only doing a hemoglobin is not enough to diagnose the anemia, because when we need to know to manage anemia, we need to know what type of anemia it is. So we also need to know that we will type the anemia and say, we would agree with a point that we are discussing only nutritional anemia today. And we also need to keep in mind that it could be thalassemia, which is not very uncommon in India. The other types may be uncommon and present to you earlier part of life that we would have probably picked up before pregnancy, maybe the hemolytic anemia and other types. So the ones which will present only probably during pregnancy is all the three types of nutritional anemia and maybe thalassemia. So we need to do a peripheral smear after your hemoglobin, and peripheral smear will tell you the type of anemia being microcytic hypochromic or macrocytic. There we make a difference. And if it's going to be microcytic hypochromic anemia, we need to do only two things: rule out iron deficiency and thalassemia. If it's going to be macrocytic, it's going to be folic acid deficiency and vitamin B12 deficiency. We are talking on a population base, so let's not go into a PG discussion and say whether I will do FIGLU test and all. That's only theoretical. But when you're going to speak to a public forum like this and to a common educational forum, we need to understand what is the cheapest and the easiest and the most practical test which we can do to arrive at a diagnosis of anemia. So if it's going to be a microcytic hypochromic, you have only two reasons. One is iron deficiency and the other is going to be a thalassemia picture. So in your complete blood count, which obviously anybody and everybody would do, you could do something called as the red cell distribution, with where that will indicate your index of anisocytosis, and that would be increased in iron deficiency anemia and decreased in thalassemia. There itself, you can diagnose whether it's IDA or it is thalassemia. With the same index, using the MCV, we can also calculate something called as Menzer's index, 13 above and below iron deficiency and thalassemia. So we get a clue whether it is iron deficiency or thalassemia there itself. Or we need not do an electrophoresis to confirm thalassemia. We can divide there itself and say. The one last test which a hospital can afford to do is your serum ferritin. Serum ferritin is always low in iron deficiency anemia, and always normal or high in thalassemia. So there we finish off your iron deficiency and thalassemia. And coming to your megaloblastic macrocytic picture, it is only folic acid deficiency or B12, leaving alone the rare forms we will not discuss. Folic acid deficiency anemia will have its particular symptoms like yellow tongue and no neurological symptoms. Vitamin B12 deficiency anemia will have a beefy red tongue, maybe with paresthesia, numbness, and tingling. And you could do a single test, a serum folate or a serum B12, and confirm whether it is this or that, so that you could treat one of them. What we need to also understand is if it's going to be folic acid deficiency or B12 deficiency, we can't treat both together because one may compound on the other. So we need to treat folic acid deficiency as folic acid deficiency and B12 as B12 deficiency, and they're very easy to treat. And having said that, what do you think is the, Premkur, anything on the diagnosis part of it? You want to discuss anything?
I think diagnosis is very beautifully covered, sir. We have talked about the peripheral blood smear, which is very, very important. That is something that we definitely need to look at. And sir, you have also highlighted about probably in some instances to look at worm infestations, we do stool for ova, etc. Those are the things that we normally do that you're very beautifully highlighted. So I think that is all. With the diagnosis, you have cleared everything, sir. So based on, of course, now that we have diagnosed its iron deficiency, megaloblastic, which are the usual two pictures, and you said it's important to differentiate between the folate and the B12. So once we have done all this, sir, their current management modality, what will you look at? Which is the oral medication which you feel would be the best? And when will you go for injectable or parenteral if it's required?
So having asked that question, I would compound only to iron deficiency anemia because that is the most common one. So coming to iron deficiency anemia, if it's going to be, we make a decision of what route of iron and which iron do we give if it's going to be iron deficiency, saying what gestational age she would belong to. So if we find out anemia in the early pregnancy, we probably would think in terms of oral iron. Oral iron is probably I'm sure the government has come out with the iron supplementation program, which we will discuss later. So the government gives 100 milligrams of elemental iron for prophylaxis. What we need to understand here, and gives it to the elder child or to the drunkard husband. The drunkard husband takes the alcohol along with iron, vomits more, and the lady cleans that rather than take the iron which is supposed to be taken. And that's a very important cause for anemia in that particular lady who's not taken the iron. So compliance is an issue with the oral iron. So having said, what is the best form of oral iron? Ferrous sulfate anhydrous form is probably the best form. There are so many molecules of iron available in the market. So if you ask us what is the molecule you need to take, there are 1,000 molecules with pyrophosphate, maltose, ferric, whatever forms. But then we need to understand to date, the approved molecule and which has been time tested is probably your age-old anhydrous form of FeSO4, and that has 77% absorption. So that is probably the best iron. And iron needs to be taken along with the major food, because I'm sure we all remember the cephalic phase of gastric secretion where there is increased hydrochloric acid. Iron absorption is enhanced by the hydrochloric acid secretion. So oral iron needs to be taken immediately or along with a major meal, whatever the meal the woman takes, afternoon, morning, night, doesn't matter. In India, we always still take it in the afternoon. You know why? Because after the husband goes to the office, the children go to school, the women eat the meal in the afternoon only properly. So that's the reason we ask them to take it in the afternoon. Otherwise, it doesn't matter whether it's afternoon, evening, or night, but the major meal. And we need to tell them what are the enhancers of iron absorption and inhibitors of iron absorption when we give them on an oral iron. So oral iron putting her will probably improve her hemoglobin by a month's time, 4 weeks of time. The hemoglobin will start improving, but within 2 weeks she'll have the feeling of well-being. So that only says that she's improved and her symptoms are improving. But then there are some women who do not have a confidence or a compliance to take the oral iron, because iron is a very potent gastric irritant. So we need to understand, in addition to her hyperemesis gravidarum and the food faddism she can have vomiting, nausea, diarrhea, constipation, and so she may not be able to hold her iron. So women who are non-compliant to oral iron, women who cannot withstand oral iron, and of course special conditions where women have undergone malabsorption, tropical screw, iliac screw, your ulcerative colitis, Crohn's disease, where there's decreased iron absorptive capacity, or they are not candidates for oral iron. So we need to think in terms of parenteral iron therapy. Having said parenteral iron therapy, these are women which we were all, when we were students 25, 30 years back, we used to give the intramuscular Z-shaped technique iron, which is the iron dextran and the iron sorbitol. Oh, gone are the days with the big anaphylactic reaction or with the big mark on the gluteus. So I'm happy that those injections which are painful, the injection abscess has gone. So we have now come with two major forms. There are many forms, two major forms. One is the iron sucrose, the other is the iron ferric carboxymaltose. The iron sucrose can be given 50 milligrams, 100 milligrams, and you can calculate the dosage with the usual formula of normal hemoglobin, patient's hemoglobin plus weight in kilogram into 2.21 plus 1000 for your supplementation. So calculate the total dose, and then you can probably give the iron sucrose 100 milligrams IV per day. Having said IV, these injections of iron sucrose do not cause any, and I'm not supposed to cause any anaphylaxis and iron reactions. So you don't need to give a test dose. So they can come to the hospital and take it as outpatient and then go back every day, if it's possible. If it's not possible, many hospitals admit them and give, but it's not required. You can come as OP and take it and go if they are accessible to the hospital. And the other molecule is the ferric carboxymaltose, which is quite popular now. There are enough hospitals, and even the government is probably taking it up and probably safe in second and third trimester, and of course in the postpartum. So advantage being a single dose of injection. You can go till 1000 milligrams of iron. It can be no anaphylaxis, nothing, so they can take it. And now the cost of the ferric carboxymaltose was going up very high when they started. But of course, that is what has happened. When we all had the cell phones, the cost was terrible. We could not afford to have a cell phone. But as we all started using the cell phones, I'm sure now even the lady who's anemic, a beggar, cannot live without a cell phone. She'll have a cell phone, but not money to buy iron tablets. But the FCM cost is coming down, and there are enough companies which have started manufacturing ferric carboxymaltose, and so ferric carboxymaltose cost is coming down, and now even the government hospitals have started using ferric carboxymaltose, and so you could use them very well. And we will probably not discuss erythropoietin and growth factors and things like that, which is beyond the discussion of this podcast.
Absolutely. Yeah. Absolutely. So, sir, very vividly put across the point when he said that it's most probably not going to cause any reaction. That's what he said. So when he says that, of course, it's important for us to note that, though we know that it will not cause reaction, but still it's important for us to keep the emergency medications probably around in case if something goes wrong. We could probably use it like hydrocortisone, etc., which might still be there in the emergency tray in the ward where you're giving this FCM. So, sir, next we would come to, as I'm the chairperson of the Public Awareness Committee, it's very important for me to look at the information, education, and communication, the IEC that we talk about. So, sir, how can IEC methods be effectively used to raise awareness about anemia among women?
Okay. So what is going on is the Anemia Mukt Bharat program, which was launched by the government in 2018. Ministry of Health and Family Welfare did launch, and the aims of the Anemia Mukt Bharat program went on to pages, and I'm sure all of us are aware of it, and the public health centers and all government hospitals and all major hospitals, whether it's corporate or government or even a public health center, are very much aware of the Anemia Mukt Bharat program, where the aims of the program was to decrease anemia by 3% per annum and to increase the iron folic acid intake by 50% and increase the knowledge as per the Public Awareness Committee, and of course go on with it. And what the government came with, what was the iron fortification programs, and of course the deworming programs came in, where the government hospitals and the government institutions were supposed to provide the midday meal with fortified iron and dal and chapati and everything with iron. But I don't know how much is it successful. So it's got a very variable success rate is what we need to say. We can't quote a success rate of those programs. But the Anemia Book Bharat program and giving iron and taking iron has definitely improved. There's no doubt about it. So that's one of the very important programs which went on. And all the hospitals now give 100 milligrams of elemental iron and folic acid supplementation. And of course, the government also, in many parts of the country, the government also gives the iron syrups and of course a protein mix of powder which the women are supposed to take. So how is it taken? Of course, the village health nurses go to the house and they give this iron tonic and the mix of the protein powders, and they take it very well. They also give an advice on how food they should take. And so the awareness has been definitely improved, no doubt about it. Oh, some time back, we were not aware of this, and the awareness and information, education, communication was very poor. Now, of late in India, the communication and the IPCs improved terribly. We did not have this some time back. To put a corollary to quote as example, 20, 25 years back, we did not know that usage of condom could prevent HIV, HPV, whatever. Oh, but now the awareness is so very good that the usage of condom and probably the sales of condom has improved a lot. Oh, we overuse, misused, abuse, that's a different story. We will not discuss that. But the awareness has improved. Oh, so also is the awareness of anemia program. And so, they should take iron tablets has improved very well, no doubt about it. But then we still have a very long way to go. So we will continue doing the information and
Perfect. So I think it's the public and the private partnership that has gone a long way in awareing the public, because we have seen in various advertisements where the government also is roping in many so-called superstars, and they are trying to, propagate very common things. One of the most common quote that we see behind the various trucks and buses, which had come in before some time, "Hum do, hamare do," which was for population control. And in fact, very recently, I came to know from one of my uncles, who is one of the inspectors in this truck inspection board or something. And he said that any truck which used to write at that point of time, "Hamare do, hum do," in that code, used to get a subsidy from the government towards the loan waiver. And that was something, that's why the truck used to write it. And that also probably has gone in a long way towards population control as well. So that is something that is important, sir. And thank you for enlightening on that. Now, we know for everything there are challenges, and challenges in awareness and treatment is one of the biggest thing that we face. So, sir, asking you, what are the biggest challenges in increasing awareness and treatment of anemia among women that you normally face, especially when you treat your patients there in Chennai?
The challenges here in any part of the country for that matter, of course, in a public health center, it is the tablets which are given free of cost. There's no doubt. But having said free of cost, the long queues in a government hospital makes it very pathetic. So the government has overcome that by asking the voluntary health nurses or the ASHA workers to go to their house and give the iron tablets and the iron syrup and the protein powder, etc., etc., etc. So that has improved the, that has probably broken the challenge a little bit. But then in the public hospitals, we need to understand that the cost of the iron tablets are a reasonable challenge to take iron. And when we write a prescription, the iron tablets with the variable, beautiful coat, inner coat, outer coat, it releases the duodenum, delayed absorption, no gastric symptoms. So beautiful iron tablets come though. So each tablet being 20 rupees, 30 rupees is not a very great idea to prescribe to the public, because I'm sure they will not be able to afford. So one tablet of iron costing 20 rupees. And so imagine she needs to take iron for the next 6 months or so. Oh, it's not going to work out for the so-called not very light lady. And even the middle class women may not be able to afford. That's one of the challenges. The second is the gastritis, nausea, vomiting is a detrimental factor for the iron. So we always can think in terms of probably why not give them a single shot of ferric carboxymaltose and then send them home, because that need not be supervised and it's only one injection. And so that's something which we can probably think in terms of breaking the challenges of taking oral iron. I agree, oral iron is probably the best form of iron because it's no side effect, blah, blah, blah. All that we can discuss, go on. But compliance is the biggest challenge we need to think. She needs to take it. A horse can only be taken to the pond. It cannot be made to drink water. So we have to make her eat the tablet is not something which is very easy. But in the hospital, when you give an injection, we are seeing her take the injection. So in that case, on that background, in India, the FCM probably scores over the iron sucrose and the oral iron tablets. In a very motivated lady, that's a different story. She takes exactly 8 o'clock alarm, phone, and then after the lunch at 12 o'clock, 1 o'clock, she takes, oh, that's a different ball game. But then in a lady who's, she's a lady is always doing multitasking. She's a wife, she's a mother, and she's a worker, and a lot of things. And so she might forget the taking the iron tablet. And so in her, probably a single shot of FCM is not a very bad idea, and that will probably break most of the challenges. And we also need to understand that we need more hoardings, we need more sayings, and I'm sure when Rajinikanth movie comes into picture, the hoardings are much more than any of the common prevalent conditions in Tamil Nadu and Chennai. So I only wish we have more hoardings for anemia and programs like that when we have a movie released. Of course, yes, those are ways where we can improve that. Tobacco chewing has come down and smoking has come down. So I'm sure anemia awareness also can come down if the media and the movie and partners like that would partner with us, with Fogsi and the Public Awareness Committee chairperson, and of course with the President Fogsi. So I think that will be another way to break a challenge of improving the awareness of anemia.
Perfect, sir. Perfect. So as you said, I think another key role or a key factor towards breaking these challenges are the community leaders. So, sir, what advice would you give to community leaders who will be looking forward probably to initiate anemia awareness programs?
The community leaders should probably think in terms of taking anemia eradication program as the most important program. When we say in a local area, it is the midday meal program in a different population. Of course, the AREC coming down is a big notion in one of the parts of the country. So each country, according to each region, has their own. So that probably needs to be unified by and taking that anemia eradication program has to be probably the most important program. We are talking of cervical cancer eradication program, excellent, but then anemia is more common than cervical cancer. And so the community leaders should probably look at anemia eradication program as one of their target for that particular area, constituency or assembly or whatever, and that will be very nice one. And two is the women in the family needs to be educated for treatment of anemia and how anemia is important. Because when you educate a man, you educate nobody. When you educate a woman, you educate a family. And when a family is educated, the whole village and the whole nation moves along with the family. And so the women needs to be aware that anemia is a very important program which needs to be eradicated. And so all methods of treatment and improving anemia, with diet, nutrition, exercise, whatever, and of course, iron supplementation should be taken as the priority by the government, Foxy, and hospital leaders and politicians as well.
Of course, everyone has to go hand in hand for this betterment in the society. Otherwise, it's going to be a little difficult. Perfect, sir. Technology and media has gone a long way, probably in helping us. We have seen in televisions a lot of advertisements, etc. But sir, my question to you would be regarding the digital platforms. Currently, we see the digital platform, the social media, where there are a lot of anemia awareness campaigns, etc. So how do you feel we can leverage this to reach out to the community level, to the rural people, to probably better anemia in general?
The digital media is not accessible to everybody is what I would feel. So the digital media is being used on Instagram, Twitter, etc., etc. And I don't know how many of the public will open the digital media. So the digital media awareness probably needs to go on in screens, in movies. I'm sure there are a lot of people who watch movie, and there can be arguments and say, oh, they don't watch movies, so it has to come in TVs. It has to come on a big forum and say on a screen, and it has to be the standee in school, which is high school, 12th standard girls. It has to be a standee in every college. It has to be a standee in every village in a public, panchayat office or whatever, so a public office, and say, then they look at, oh, what is this board, and we will go on. And that will probably improve the awareness, and the digital media will probably until it goes and percolates into the villages, it's difficult. So we'll have to use other targets other than only the digital media will reach the elite population, no doubt, but it will not reach the villages. So to go into the villages, we need more help from the local village people, the panchayat, and having hoardings and statements from them.
Perfect. So I think it has to all go hand in hand, as you said, sir. Digital media, yes, will target probably the elite class, probably the bigger towns, the metro cities, etc. But we need to target the actual targets. That is the population that stays in the villages. There has to be hoardings, etc. Probably messages from the school education programs, etc. That can be looked at in probably addressing this sort of a scenario. Now, so coming to the future direction, of course, advancements, research is something that we love doing, but towards anemia, what advancements or research do you feel will be the most exciting in this field of anemia treatment and prevention?
It is probably very theoretical, but what advancement I would look at is, when we say a single stop for treatment of everything. So there are a lot of places which say, when we have a hoarding for a mall in whether it's in Siliguri or Mumbai or Pune or Chennai, or the single stop mall for shopping everything. We go into a mall and we buy everything, whether it's from food to jewelry or electronics, we buy everything. So my dream would be that a single stop treatment for anemia, or a single pill or a single injection, which probably if you take it, the anemia should go off. So I'm sure the advancement has to be that way, where we need to involve engineers, pharmaceutical companies, geneticists, whomever, and of course the doctors, logicians, and research scientists who will probably prepare a molecule of oral tablet or injection, whatever may be, a single shot injection which will prevent or treat whatever may be the anemia, whether it's iron deficiency, folic acid, B12 deficiency, at least the nutritional anemia could probably be treated by a single injection. So that is the day when I would say, oh, we've evolved like Japan or whatever revolutionized country. And so that is probably the dream which we all Foxians have to dream and say a single shot injection would probably treat or prevent anemia.
Perfect. So I think Sunita ma'am will be proud of this initiative that you're talking about as well. She talks about the Do Tike Zindagi Ke, which is regarding the HPV vaccination, and we can talk of one shot anemia bhagao sort of a campaign as well, where we could look at in the future as well. Thank you so much, sir, for envisioning that, because I think someday, of course, we will be able to see that that has light as well. Now, the last part, we've got the last 5 minutes, and I'm now going to take personal insights from you. You have worked in this field for, I think, so many years now. There are a lot of your students who are watching this program as well. So I would like to ask you to share a memorable experience or success story from your practice related to anemia management. I'm sure all of us have that one sort of an instance regarding most of our diseases that we treat, which was something that was a lost sort of a battle, but then again, proper management, etc., brought it back together. So what would be your memorable experience regarding anemia, sir?
I would still remember two of my cases. I'll put it very short. Both of them were treated outside in a smaller hospital, not to blame any hospital. One was pregnancy, anemia treated, and then, they gave all forms of iron, and she did not respond to and came to us in advanced pregnancy, a thin and cachexic looking lady. And, when we pondered into the history, we found out that when we were doing rounds, I asked, what is your usual habit? Oh, then she started slowly telling that. And then she said, I will chew tobacco. Then I asked her, would you smoke? Oh, it's a very big sin if I ask a woman in South India whether she will smoke. Oh, but she was a chronic smoker. And then over probing the history, she had a history of tuberculosis, but she did not have cough. So if it was cough, my intern would have picked it up and then said it's, oh yeah, cough and then whatever. So then we did an X-ray. Oh, absolutely a tuberculous lung. And then we decided that she was tuberculosis and then referred to, of course, pulmonology, and they took over and anemia treated. And then the lady went home quite well. And of course, we had to give blood at that point of time, but blood was a treatment because she was an advanced pregnancy. But then we picked up tuberculosis in her, which was absolutely missed in the last, whatever, 6, 7 months of pregnancy. And so that was one of the very success stories which I very vividly remember. The second of the condition which women came with anemia, and then treated with iron, and they gave all forms of iron. Very recent history, oral iron and then IV iron. They changed from one molecule of sucrose to another molecule of iron sucrose, and then FCM and all the possible combinations, and her hemoglobin would not improve. So she came to us, and only CBC was done in the routine investigation. CBC hemoglobin was 8.5. The next day repeated different, and then the CBC did show that it had reticulocyte count and basophilic stippling. Oh, and then we said, oh, it could be thalassemia. And so we did the Mensa's index was quite high. And so then we gave blood, and this patient went home very well. And luckily she was pregnant and she was thalassemia. And so when we screened the husband, then husband had thalassemia trait. So we had to screen for the baby and then say, oh, there is the baby thalassemia. Luckily, 1 in 25. And so the baby was not a thalassemic baby. And so that's another success story. And the lady said, I will screen this baby for anything. And when this baby gets married, I will screen the partner, whether that partner is thalassemic or not, and things like that. So she was very educated when she went home that it was not iron deficiency, it was thalassemia. And so we need to screen the lady and to the progeny to say that whether this is thalassemia can run in families. And yes, so I was happy that that family became very educated for thalassemia. And so this was the second success story of anemia relation things. And so very happy to share that two cases, which I remember very vividly as success stories of anemia.
Perfect, sir. I think two important messages that sir has given also with this. Number one is that pregnancy doesn't mean that you cannot do chest X-ray. You can definitely do with the abdominal shield earlier, but later on, even without an abdominal shield. And the next question that sir has, next important point that sir has made is in case of thalassemia, do not give injectable or oral iron. You have to give, but then it doesn't work that very well. So it's better to give a blood transfusion if the lady goes into a very low sort of an anemia state. Thalassemia, we have to manage it well once it's diagnosed. So, sir, the last question for the day. Thank you so much for answering all the questions so patiently and so elaborately as well. So, your take-home message for today's entire show that we had. So, what would be your take-home message to all the gynecologists who are seeing you today on this program?
The only message which I want to give as far as anemia is related, I think we need to take the president's message and copy it here. We need to be prepared for anemia, prepared for pregnancy, and not treat anemia after it comes. We need to think in terms of anemia even before it comes, because the devil cannot strike us at surprise. And so we need to treat anemia, yes, but we need to prevent anemia as something and be prepared to treat anemia, and we cannot be struck by surprise.
Perfect. So I think things that we probably predict from before, we treat them well. And of course, in anemia, as it's always said, that prevention is something that we always see as it's better than cure. So because obviously we need to look at a picture, we need to diagnose it, and then we need to take it forward. So the whole point of basically taking this forward was we were looking at a sort of an anemia day anemia. We were looking at a picture where we were looking at an awareness sort of a picture towards anemia. And this is something that we wanted to discuss today. And thank you so much, Palaniappan sir, for your beautiful insights. We have got beautiful points to ponder, points to think forward, but more importantly, got the recent advances in how to go about in managing them. So thank you once again for this wonderful program. We'll definitely look forward to meeting you again tomorrow, 8 p.m. with another episode of the podcast series. That will be the episode number 23. So as of now, me and of course, Dr. Palaniappan sir, our guest speaker today, will be signing out, but we will definitely come with a fresh show tomorrow to give you more insights about various other topics in the coming days as well. So thank you so much once again for viewing us today. Thank you so much, Palaniappan sir, for being here, and thank you for sharing your insights. Thank you, Sunita ma'am, for your giving us this opportunity to conduct this program as well. Thank you, Palaniappan sir, once again.
Thank you, Priyanku. That was lovely. And thank you, Dr. Sunita and the media team who supported. Thank you very much. And we will come out with more enthusiastic programs like this. Thank you very much, Priyanku.
Thank you so much, sir. It was a pleasure to get those insights from you today. Thank you so much.